Good evening, everyone. Welcome and thank you for joining us for this new webinar of the Pediatric Society of the African League Against Rheumatism, PAFALR. My name is Katime Lontaleng. I am Cameroonian rheumatologist and I will moderate this session. The speakers today is Dr. Iman Al-Milati, who is pediatric rheumatologist. She works in the pediatric department of the Children's Hospital in Tripoli. She is a member of the Libyan Society of Rheumatology and also a member of PAFALR. The topic of her talk this evening is a rare and under-recognized disease, a journey for 2007 to 2022. Please, if you have the question for this presentation, you can put your question inside the answer and response box, and Dr. Iman responds after the presentation. Dr. Iman, welcome. You have the floor.
Thank you, Dr. Kathy, for the warm introduction. Good evening, everyone. First of all, I would like to thank the PAFALR to give me the opportunity to be the speaker today. I feel really blessed and honored. My presentation today is about a challenging case journey from 2007 to 2022, titled A Rare But Under-Recognized Disease. I have no disclosure. I have followed up this patient since 2018. So Prof. Dr. Saad Hashad was the treating physician for this patient, and she faced the whole challenge in the story and solved the whole puzzles. So I would like to take the chance to say a big thank you, Dr. Saad Hashad, for continuous support and your guidance in preparing this presentation. This is the content of my presentation. The story started in 2007, a 12-year-old Libyan girl with no comorbidity or positive family history of autoimmunity presented with 2-month history of cold extremity and symmetric inflammatory polyarthritis of the small joint of large joint for the 2 months. Other systemic review was unremarkable. On examination, she has arthritis of both knees and small joints of both hands. Giving the presentation and the examination, our provisional working diagnosis that she could be a case of polyjuvenile idiopathic arthritis or juvenile SLE or a case of an overlap syndrome. So initially, waiting for the result of investigation, we treated her arthritis with naproxen and methotrexate. The result of investigation, CBC was normal, high inflammatory marker ESR was 67, high GOT, high GBT, ANA was positive, anti-double strands was positive, anti-SM borderline, anti-RMB was normal, and she had normal C3 and normal C4. She partially fulfilled the SLIC classification criteria of systemic lupus erythematosus, but because she has a clinical and laboratory finding that compatible with autoimmunity, we consider her as incomplete juvenile SLE presented with arthritis that didn't respond to naproxen or methotrexate. So we started her on steroid. Her joint manifestation and her lab marker were improved. 6 months later, the treatment was stopped by the family. 1 month of treatment, she had a rapid decline with ankle and knee arthritis, high ESR, high liver enzyme, proteinuria in 24-hour urine collection. We restarted her on steroid. During the first years of her illness, her joint symptoms, inflammatory markers, and liver enzyme were steroid dependent. It improved by steroid and relapsed on stopping the steroid. She had normal C3 and C4 and normal anti-double strand antibody. So she was kept on 5 milligrams of steroid. During the second year, she started to have a new complaint. She started to have again high liver enzyme, proximal muscle weakness, and myalgia. Re-evaluated, she had a high muscle enzyme, aldolase 23, CBK was very high, 3,000 and 400, LDH very high, hepatitis screen were negative, ANA and anti-double strand and ENA all were normal. Antiphospholipid antibody was negative, C3 and C4 was normal. So we reconsider diagnosed and diagnosed her as a myositis presented with arthritis, or again, a case of an overlap syndrome. We treated this flare with pulse steroid, methotrexate restarted, and put her on IV immunoglobulin on regular basis. On follow-up, she has no complaint, normal muscle power, normal liver enzyme, and muscle enzyme. In 2010, her symptoms were improved. She had also normal CBC, normal liver enzyme, CK, and LDH also was normal, but she has some reading of high ASR from time to time. So we started steroid tapering while she was on 2.5 milligram of prednisolone. She admitted to the hospital with severe pneumonia for 11 days, treated by IV antibiotic. She again started to have muscle weakness. CMAS was 34, EMG showed myopathic change. Again, ANA, anti-double strand, and INA all were normal. This flare again treated by pulse steroid. In 2011, she is on IV immunoglobulin, steroid 5 milligram, and methotrexate. She was asymptomatic with normal examination, but she still continued to have abnormal lab. She has a very high CK 6000, LDH 400, GOT and GBT were both fluctuating. The action we have done at this time, we stopped methotrexate because of high liver enzyme, started her on cyclosporine, and continued her on IV immunoglobulin on monthly basis. During this course of her illness, her muscle manifestation had improved, but she started to complain of intermittent cough and dyspnea. 2012, again, she is on cyclosporine. She is on very low dose, 2.5 milligram prednisolone. Our patient started to have respiratory symptoms with exertional dyspnea, cough, and recurrent pneumonia. She had a clubbing of finger, rhinoid phenomena, myalgia, CMAS was 32, microcytic hypochromic anemia, high GOT, high GBT, LDH and CBK were very high. CT chest show inflammatory fibrotic change in both lungs. Pulmonary function test showed mild restriction and severe obstruction. Immunoglobulin studies sent for her and were normal. Here, one of the INA antibody, what we call anti-Jo antibody, was positive, and it was very high. At this point, when we applied the diagnostic criteria for anti-synthetase syndrome, it fulfilled both criteria for anti-synthetase syndrome. Finally, we nominate her as a case of anti-synthetase syndrome. Cyclosporine was stopped. We treated this flare again with IV methylprednisolone and started her on cyclophosphamide tablet. Here, I would like to stop and to say why it was very difficult to diagnose the case and to put the puzzle together. Anti-synthetase syndrome is an autoimmune disease characterized by the presence of antibody, anti-amino acid tRNA synthetase antibody, which are the serological marker of anti-synthetase syndrome, and characterized by the presence of clinical triad of inflammatory myopathy, arthritis, and interstitial lung disease. Anti-synthetase syndrome is a rare disease with a global prevalence estimated as 1 to 9 person per 100 person. There is no precise data on the disease incidence until now. The clinical manifestation of anti-synthetase syndrome has a varied combination at the onset, not always present at the onset of the disease, and it may arise over time, even when the treatment has already been instituted. Regarding the muscular involvement in anti-synthetase syndrome, it ranges from isolated increased serum concentration of muscle enzyme to severe weakness and mobility impairment. Isolated myalgia without muscle weakness also has been described. The arthritis and arthralgia are common signs in anti-synthetase syndrome, and symmetrical polyarthritis affecting predominantly proximal interphalangeal, metacarpal, phalangeal, or wrist joint is very common. Rhinoid phenomena ranged from 8 to 65% of patients, was the initial manifestation in 17% of patients with anti-Jo antibody, most frequent in patients with polyarthritis in the course of the anti-synthetase syndrome. Regarding the pulmonary manifestation of anti-synthetase syndrome, it increased the morbidity and the mortality of the disease. Again, it's range from asymptomatic lung fibrosis to an acute, rapidly progressive process and respiratory failure. Most common clinical pattern of interstitial lung disease in antisynthetase syndrome is the gradual progression of non-productive cough, dyspnea, and decreased functional capacity. So once we diagnose a case of myositis, this mandates careful assessment of underlying interstitial disease. In patients with idiopathic inflammatory myositis and symptoms of dyspnea, cough, or decreased functional performance, it's important to obtain a chest radiograph, high-resolution CT of the chest, and pulmonary function test on regular basis. As I said, antisynthetase syndrome is characterized by the presence of a clinical triad and the autoantibody. There is an 8 autoantibody known until this time. The clinical spectrum with the different autoantibody is not identical. For example, anti-BL7 and anti-EG antibody associated with rapid progressive interstitial lung disease and lower frequency or absence of myositis. On the other hand, anti-Jo is a strong predictor of interstitial lung disease, and myositis occur most frequently, and patients with anti-Jo antibody had a better outcome. In 1981, Walker et al. Discovered anti-Jo antibody occur frequently in a cohort of patients with dermatomyositis and polymyositis, but it takes 10 years to consider these patients with those antibodies to be recognized as having a distinctive phenotype. And again, it takes another 10 years for available criteria for diagnosing, antisynthetase syndrome to be available. Again, all these 3 criteria come from expert opinion and lack validation or performance assessment. So these all criteria not validated yet. The lack of validated criteria resulted in patients often misdiagnosed as having either idiopathic pulmonary fibrosis or dermatomyositis or polymyositis. This leads to under-recognition and misclassification of this syndrome, which is associated with high mortality and high morbidity. To overcome this limitation, the ESR and EULR had a class of projects with the goal to develop a validated classification criteria for antisynthetase syndrome. So until today, there is no validated classification criteria for the antisynthetase syndrome. Back to our case, as I said, she is now diagnosed a case with antisynthetase syndrome with restrictive lung disease. The challenge didn't end by the diagnosis of the case, but the challenge continued in treating the patient also. Back to our patient, 2013, she is in prednisolone, 5 milligrams cyclophosphamide. She had no arthritis, no myalgia, no myositis. Her CMAS was normal. Her labs all were normal, but she continued to have recurrent chest infection. Cyclophosphamide stopped, and we started her on azathioprine to treat her pulmonary manifestation of antisynthetase syndrome. 2014, this stage of the disease was considered serious and diffuse. She got the worst relapse in her disease in both muscular and pulmonary manifestation. The pulmonary involvement was the major clinical topic of the girl and influenced her long-term survival. She had a progressive, slow worsening of dyspnea and cough, chest pain. She had clubbing, cyanosis. Pulmonary function test was characterized by severe restrictive lung disease. She had bilateral pleural effusion. CT scan of the chest showed interstitial lung fibrosis. Again, she has a muscular flare in form of severe muscle pain, myalgia. Her CMAS was 27. She has a flare of her arthritis of right ankle and left knee arthritis. Again, her lab were abnormal. She has anemia, high ESR, high liver enzyme, high LDH, and high CK, and high aldolase. This flare treated again by pulse methylprednisolone, and here at this time, lung transplantation was considered for her as soon as possible in highly advanced center to save her life. Azathioprine was stopped because it failed to control the pulmonary manifestation of disease, and we started her on mycophenolate. While waiting for the preparation for lung transplantation, her disease started to show some mercy on her. So initially, she started to have a clinical remission, no pulmonary, no muscular manifestation, no arthritis, normal CMAS, but continued to have abnormal labs. She has high HSR, high GWT, high GBT, high CK, and high LDH. So we increased the dose of mycophenolate. Since 2016, since then she has a clinical and lab remission, normal, no pulmonary or muscular manifestation, normal ESR, normal LDH, normal GOT, normal GBT, and her CMAS also was normal and had a static high resolution CT chest change. Due to drug compliance, we had respiratory flares in form of severe respiratory symptoms, high SR, high GOT, and GBT, and again, she has a flare of her myositis. Her CT chest show mild progression of a previous finding. We restarted her on steroid again and doubled the dose of mycophenolate. And here she is today, a very strong warrior who is taking care of her family. The journey of this girl taught us a lesson. So another girl, she was a 9-year-old girl presented with arthritis, rhinoid phenomena, and high LFT. From the beginning, we suspected her as a case of anti-synthetase syndrome. So we requested anti-Jo antibody, which became positive. She was asymptomatic and has no pulmonary manifestation, but had abnormal high-resolution CT scan. We started her on steroid and methotrexate. Initially, she did very well until she was in 2.5 milligrams of steroid. She relapsed with pulmonary manifestation, high resolution of the CT chest, showed ground glass opacity bilateral. We treated this flare by induction with IV methylprednisolone, and here we started her on mycophenolate. Since 2007 to today, she has a normal high-resolution CT scan, chest, and normal manifestation, normal lab. The treatment of anti-synthetase syndrome is very challenging as there is no well-defined treatment scheme. There are no precise therapy guidelines. Most data on the treatment are retrospective or uncontrolled. All studies were on adult population. Corticosteroid can be used as initial management of active disease, but when used as monotherapy, there is a frequent lung disease recurrence with corticosteroid tapering. Frequently used adjunctive agent for the refractory muscle or lung disease is azathioprine. Azathioprine used mainly for myositis, predominant symptoms, and arthritis. Mycophenolate used mainly for the pulmonary manifestation of the disease. Cyclophosphamide reversed for the severe or refractory anti-synthetase syndrome associated with interstitial lung disease. Intravenous immunoglobulin can be used to treat the myositis, but has not been used as frequently to treating the pulmonary manifestation of anti-synthetase syndrome. There were no significant difference between the outcome of these different adjunct agents. Patients with severe disease and progressive disease despite immunosuppression may benefit from referral for lung transplant. Asymptomatic patients who have mild abnormality on pulmonary function test or high resolution CT scan should be closely follow up by clinical symptoms and pulmonary function test. However, there are no accepted recommendations for the treatment of asymptomatic patients. Other clinical features may guide the treatment. So to conclude, due to its clinical trajectory response to treatment and the prognosis, that anti-synthetase syndrome should be viewed as a distinct standalone phenotype. We should be aware of cases that begin only with isolated muscular, articular, or pulmonary involvement. Anti-Jo antibody offers a simple addition to the usual investigation of myositis. Therapy is targeted to the system and organ involved and based on the severity of symptoms.